You are live now, sir.
Good evening, everyone. So, welcome to the first episode of Corneal Surgery Learning course. And I am grateful to Georgia Surgicals because they are supporting us in this program. And I request our president of Delhi Ophthalmic Society to say a few words. Then I'll introduce the panel and then we'll go ahead with the program.
Thank you, Praful, and thank you, Dr. Yasin, and of course the entire panel for helping us kick off this DOS Super Tuesday corneal surgery learning course as in a super manner. And I'm sure this is going to be a wonderful talk and session. We have some of the best in the business in corneal surgery with us here, who of course will take the discussion forward. And we will keep meeting you in multiple ways, both online and physically, in the next few months as we go forward. And thank you everybody for coming, participating, and I really look forward to a great session. So Praful, I think we'll move quickly to the main session. Thank you, everyone.
Thank you, sir. So I would like to welcome Dr. Hazem Yassin from Egypt. He is a professor. He's interested in cornea and enter segment. He's a professor in the Cairo University, Egypt, and an excellent corneal surgeon. He conducts a lot of courses on corneal surgery, DALK, including AIOC. I think last Kolkata also we had an opportunity to go through his course. And our expert panel today, again, all stalwarts in corneal surgery, Professor Namta Sharma from RP Center, Dr. Rajesh Fogla sir, Professor Rajesh Sinha, Dr. Vikas Mittal, Uma Sidhar ma'am from ICARE Group of Hospitals, and Professor Amit Gupta from PGI Chandigarh. I'm going to moderate this session, and we have some discussion. I think they are the most essential part of this of the discussion part. Dr. Saran from Narayan Netralaya, Dr. Rohit Bang, Dr. Chandra Devi from RPC, Dr. Nishtha from New Delhi, Dr. Shraddha from Mumbai, and Dr. Soham. All of them are excellent corneal surgeons, young surgeons, and they have some difficult situation which they are going to put forth, and we'll be discussing that. We have panelists, Dr. Shefali, Dr. Bhupesh Singh, Dr. Rajat Jain, Dr. Pandita, and Dr. Aditi. Again, these are our young budding corneal surgeon, and they are again going to put their inputs in the discussion part. So I welcome you, Dr. Hajim, and you can start your talk. And yes, before the last thing is actually it was supposed to be one session, but as we discussed with Dr. Hajim, he wanted to first do a basic step-by-step DAL course, and then our next episode maybe we will be covering the difficult, challenging parts. So today's program will be focusing on learning DALK step by step. Dr. Hazem, you can take over from here.
Hi, everyone, and thank you very much for this kind invitation. I'm actually very honored to give my talk here. And honestly, I'm very happy because I received many of my mentors come from India, and I got many tips and many educations. And this is why I always say that India is the land of wisdom, surgical and medical skills at the same time. In order not to waste time, let's start our course, and I hope it will be kind of like beneficial to all the audiences. And we're going to talk to the audiences about step-by-step DAL course. And I want to thank this guy because this guy is not only a guru in educating, it's inspiring when you listen to him. It's inspiring when you get close to him because you learn how to get the surgical tips and medical tips at the same time. He's giving you the pleasure and he's giving you the power in order to share what you have in the operating room. Thank you very much, Dr. Rajesh Fogla, for all what you taught me. The course will include the introduction and patient selection. Then we'll go to the preoperative examination. We'll discuss the instrument, surgical techniques step by step, and postoperative care. Probably we are going to postpone the complications for a future course. Now we're going to go for the introduction. And we all know about the surgical anatomy of the cornea. And here is kind of like a schematic for the layers of the cornea. I believe the most important layer is the Dewey's layer. This man has introduced a concept in the anatomy where you all know that the anatomy is kind of like there is no innovations in the anatomy, but Dewey's layer has changed a lot in the DALK future and the outcome. And here is the anterior lamellar keratoplasty, whether it is superficial anterior lamellar keratoplasty or deep anterior lamellar keratoplasty. I don't want to waste time in these repeated slides in every course. And here is the anterior lamella where you have the epithelium and Bowman's membrane, you have the stroma, and the posterior lamella where you have the endothelium, desmids, and posterior stroma. Types of the anterior lamellar, this is kind of like a historical revision, but let's go from here, the Anwar's big bubble technique, where in 2002, Muhammad Anwar introduced the big bubble. Then came Sir Nicola Ten and Fogla introduced the cannulas, which made a major breakthrough through the outcome of the DALK without perforation. And then with the use of the visco bubble dissection with the Sir Nicola, it improved a lot of the outcome of the DALK. So what is the patient selection? We have to examine the slit lamp. We have to get the anterior segment OCT and the Scheimpflug image by pentacam in order to detect thickness of the cornea, integrity of the Dewey's layer, and descemes membrane. Because you know, if there is previous hydrops, the descemes membrane and Dewey's layer are perforated, so you might as well change into manual DALK. What are the instruments? These are a bunch of instruments, the spatula and the point dissector, the DALK's pocket forceps, the lamellar dissector, the scissors right and left, and of course, the most important is the air injection cannula. I believe that Indian doctors are very lucky by having Georgia Surgical. And one of their innovations is having all the DALK instruments, but in titanium blue tinged instruments. And this helps a lot, as I will show in the course, in the videos, that the blue titanium versus the surgical emphysema or the corneal opacities make the introduction of the instruments is much easier. So these two dissectors, the normal tan, the dissectors help a lot in mechanical dissection at the edge of the graft host junction or in mechanical dissection as well. What are the surgical steps? And these are the most important things that we are going to focus in order to make the DALK as easy as possible. So these are the 9 steps of the standard DALK technique. Number 1 is the centration and marking. Once we get the centration and marking, we go to the trephination. Then we are going to have a debate about the paracentesis, whether we do it before or after air injection. And then again, are we going to have a debate about the initial stromectomy, whether we're going to do it or we're not going to do it. If we're going to do it, we're going to stick to the upper 1/3 of the cornea from 12 to the mid-third of the cornea or no. Then we're going to go for the air injection, and we have to understand the possible outcomes and identification of each outcome. Then after that, we're going to discuss the big bubble and the brave slash. Then the next step, or the 7th step, is the cruciate stromal quadrant removal after the big bubble scape. Then we're going to talk about the trephination of the graft, then suturing of the graft. These are the 9 steps. We're going to go through each step with discussion. So this is a schematic of what we're going to see, the centration before the trephination. And then we start the trephination, again, the paracentesis before or after the air injection, then the big bubble injection, and then incising the big bubble into 4 quadrants. Then we do the stromal excision in layer by layer dissection, then the stromal quadrant removal of the big bubble. and then the donor suturing. And these are the major steps. Number one, we're going to talk about marking and centration. Always remember that the field should be dry. And I'm going to count 5.5 millimeter caliber. And then I'm going to rest on the limbus in the 4 cardinal directions as seen here. So I will have like 4 points. And these 4 points, I'm going to choose a point between these 4 points. Of course, every surgeon has his own way in order to detect where is the geographical center of the cornea in relation to the center of the pupil. But always remember, this should be dry, because I always see my assistant nurse, whenever she opens the drape, she flushes the eye with the ringer lactate or saline or something like that. So always keep the bed dry. Now we're going to talk about the trephination. We have to understand our trephines, and we have to be at the same time on land of reality, because some of us, me for example, we used the used trephines before. So if the used trephine, then we have to adjust the trephine to the 0 position, and if they are new, then I know that they are adjusted. We have different trephines. Some of them European and American, the Katina and the JedMed. Coronet is not that much into the market nowadays. I love the Madu, although the Madu doesn't have this crosswire centration, which is extremely important in order to centralize the suction trephine over the chosen part of centration of the cornea. So the trephine adjustment, first adjust to the 0 mark. I'll align the blade with the vacuum chamber. Here's the vacuum chamber, and here is the blade. So you have to align this together at the 0 position. You might withdraw like 3/4 in order to be like 150, 160 microns above the cutting start of the trephination. Moving the blade clockwise, this means towards the cornea, so it's cutting. Anti-clockwise means that I'm moving the blade away from the cornea. And moving the blade each quadrant means that I'm turning and I'm moving the blade 60 microns deeper to the cornea. So now I want to have a proper calculation of the number of the turns. You don't have to calculate this number, which is the central thickness. No, you have to calculate the number on the periphery at the 8 millimeters or 8.25 millimeters thickness. So what happens is that the site of perforation at 8 millimeters, I will choose the thinnest pachymetry of the circumference of the 8 millimeters. Then I'm going to count 80% of this thinnest pachymetry. This 80% of the thinnest pachymetry, I'm going to divide it by 6 microns. When I do that, it will give me the number of quarter turns. I mean, it will give me how many turns I'm going to do. Because each turn, each quarter turn is 60 microns. So it will give me the number of quarters clockwise trephination. Now I'm showing you that here is the, this arm is kind of like stripped like this, so that you know that when you do it 4 times, this means that it's 1 turn. So usually it's about between 6 and 7 turns, 6 and 7 quadrants. And it's very easy that you can see the start of the trephination. Once you do that, you start elevating the edge in order to determine whether it's an adequate depth or no. So now, after finishing the trephination comes the paracentesis. And there is a big debate whether we're going to do the before the air injection or after the air injection. If we're going to do the paracentesis before the air bubble injection, this might lead to sudden expansion of the big bubble since the anterior chamber is empty, so there is no resistance. The big bubble might perforate due to sudden expansion, and it might perforate into the anterior chamber. Don't forget that the maximum diameter is 8 to 8.5 millimeters. So this means that the paracentesis should be directly in this direction. If I'm showing my hand in this direction, directly towards the optic nerve head. And always aim at the blade direction vertically at the limbus. But if we do the air bubble after, or the paracentesis after the air bubble, this means that I have controlled the expansion of the big bubble. After paracentesis, I can expand the big bubble more by continuing injection. Do not forget that the maximum diameter is 8.5 and always aim that the blade direction is vertical at the limbus in order not to deflate the bubble from inside. As you see here, it's very important, should be directly towards the head of the optic nerve. Then you have to deflate. If you want to increase the diameter of the big bubble, then it's okay. But again, I don't find any reason because the diameter of the big bubble, if it's type 1, usually it's between 8 to 8.25 millimeters. And what I want is that the air bubble exceeds the trephination edge. If this happens, this means that all the bridges, intertissue bridges, are cut beyond the graft or beyond the trephination edge, as will be seen in the future in the next videos. Step number 4, are we going to do initial stromectomy or no? Number 1, to do it or not to do it, this is a question. Before or after air injection, this is another question. And then, are we going to do it before or after paracentesis is the third question. Let's discuss, are we going to do initial stromectomy or no? Well, of course, in manual layer by layer, we are going to do initial stromectomy. But in big bubble DALK, it all depends on the initial corneal thickness. For example, for a big bubble to reform, there should be enough, at least 100 to 150 microns roof. So the roof of the bubble, in order to maintain the big bubble, should be at least 150 microns, which means that this area should be thicker than 100 microns to 150 microns. If the stroma is very thin, this means that I cannot do the stromectomy, initial stromectomy. If this happens, this means that the roof of the bubble will not maintain the big bubble, but it will be small frothy bubbles escaping from the roof because it's very thin. So, of course, removal of the initial stroma will facilitate either gaining the big bubble by decreasing the thickness of the roof and better chance to get the big bubble, or it will facilitate the brave slash and quadrant removal. So, we have to look carefully to the initial corneal thickness. If it's more than or equal to 400 microns, then you do it in order to increase the chance of getting the big bubble. So this means that I'm going to do the initial stromectomy before injecting the big bubble. If it's between 400 and 300 microns, do it in the upper 1/3 only. You know that the thickness in the lower half or the lower third is going to be thinner and thinner because of the ectasia of the keratoconus pathology. So only do the stromectomy in the upper 1/3, and this will facilitate getting the air bubble. If it's between 300 and 200 microns, do not do the initial stromectomy, as the roof will be very thin to hold a big bubble, and what will result is small frothy bubbles that escape from the roof being very thin. So before, if 450 or more, and after, if you gain good big bubble, if less than 400, and after, if associated with a mixed bubble. So are we going to do the initial stromectomy before or after paracentesis? Again, this is another debate. Before paracentesis, this will give the benefit of shorter time of contact between the desmus membrane and the iris. Once paracentesis, there is direct contact between the desmus membrane and the iris, which decrease, we want to decrease as much as possible in order to prevent the touch between the endothelial cells of the recipient and the iris tissue. as we see here, what we aim at is the last part of this whitish area, this emphysematous whitish area. So I am dissecting here, not in the roof of the whitish part, no, in the deep part, so that by this way I'm removing more stroma, leaving less roof, which will be thinner for the future or the next grave slash or de-roofing or opening of the big bubble. Now we will talk about the air injection and the possible outcomes. Of course, as we saw before, that we're going to inject the air in the bed of the deepest part of the trephination. So we have to elevate the graft or the site of the trephination in order to determine the depth. What are the outcomes of the big bubble injection? So we might have the type 1 bubble or type 2 bubble or type 3 bubble. So type 1 bubble, this means that I have the stroma above the bubble and I have the Dewey's layer and Descemet's membrane below the bubble. This is the roof and this is the floor. Meanwhile, in type 2 bubble, this means that I have the stroma and Dewey's layer above the bubble, making the roof. Meanwhile, the floor is only made of the Descemet's membrane together with the endothelium. Sometimes we have this name, which is type 3 bubble. This means that we have type 1 or plus type 2, plus or minus an anterior chamber bubble. So we have partial type 1 bubble, partial type 2 bubble. Sometimes in very rare situations, we have complete type 1 and complete type 2 bubble, plus or minus type 3 bubble. So in all these, we will show what's called the vanishing dimple sign. I want you all to imagine that we are pressing over the stroma here. So there is an indentation of the cornea, which makes this part indented in a concave manner towards the anterior chamber. Once you inject the air bubble, this means that the roof of the big bubble will be convex and the dimple sign will vanish. So if we have a persistent dimple sign, this means that we didn't gain the big bubble or we didn't gain a bubble, whether big bubble type 1 or type 2. And this means that we are having surgical emphysema. At that moment, we either do initial stromectomy and then retry another big bubble trial, or if failed, then we are going to continue as manual DALK. As you see here, these are the characteristics of type 1 bubble. It's a silver white appearance, and the edges are fuzzy like this, and it's not transparent. And it's definitely not more than 8.5 millimeters. But if you look at this part, you will see that the big bubble here is with a transparent and a bigger diameter that might go even to the periphery of the limbus. This is type 2 bubble. Again, the characteristics of type 1 bubble, non-transparent, white edges, never more than 8.5 millimeters. If we have type 1 bubble, this means that we will continue as usual, which means stromectomy followed by de-roofing or opening of the bubble, then quadrant removal, and then suturing of the graft. But what if we have type 2 bubble? Number one, we have to identify that this is type 2 bubble. Of course, here it's very evident then that this edge is type 2 bubble. Okay? It's transparent, clear edges. The diameter is bigger than 8.5 millimeters and might reach to the angle. What is the management of type 2 bubble? This is extremely important, and because sometimes I feel that my colleagues, they become very nervous and kind of like edgy if they get type 2 bubble because they don't have a scheme of how to deal with type 2 bubble. Management of type 2 bubble. let's all agree it will have a higher incidence of a double anterior chamber. Hence, it will need air injection in the anterior chamber. Once there is air injection in the anterior chamber, this means that I will need peripheral inferior iridectomy to prevent the pupillary block. Let's all agree that type 2 bubble we have to deflate. So these are three agreements. It's higher incidence of double anterior chamber. We have to have an air injection in the anterior chamber, and we have to deflate. What are the possibilities? It's one of those three possibilities. Either type 2 bubble together with type 1 bubble plus or minus anterior chamber bubble, or type 2 bubble plus surgical emphysema, or type 2 bubble alone. These are the possibilities. So in all situations, if I have type 1 bubble, this means that I'm going to continue as usual. So if I have type 2 plus type 1 plus or minus air bubble or bubble in the anterior chamber, I'm going to continue as if I have type 1 bubble. Stromectomy plus or minus, brave slash, then either deflate type 2 bubble from the center of the floor of type 1 bubble, but you will need another opening at anterior chamber at 6 o'clock to prevent, to do the peripheral iridectomy, or you can use the keratome incision at the limbus at 6 o'clock. And this will deflate type 2 bubble at the same time open the anterior chamber for inferior peripheral iridectomy simultaneously. I'm going to show my hands like this. This is 6 o'clock, and I'm going to introduce the keratome at 6 o'clock, or let's do this at 6 o'clock. So this is the surgeon site at 12 o'clock, and this is 6 o'clock. So I'm going to introduce my keratome at the limbus at 6 o'clock. This means that I made an opening in the stroma, followed by Dewey's layer, followed by desmus membrane, followed by anterior chamber, all through. Then I will take inferior iridectomy, and then because there is a release incision in desmus membrane, then I can milk any type 2 bubble wherever it is. If I have type 2 bubble together with surgical emphysema, then forget about the bubble. Consider yourself as if you didn't get type 2 bubble. Consider yourself as if you have a surgical emphysema and continue as manual stromectomy and manual DALK. As much as you can, then deflate type 2 bubble by the keratome at 6 o'clock limbus, then do the inferior iridectomy, then air into the anterior chamber. Type 2 alone, forget again about the bubble and continue as manual stromectomy. As much as you can, then deflate type 2 bubble by the keratome at 6 o'clock limbus, and then do the inferior iridectomy, and then air in the anterior chamber. Please resist the temptation of deroofing of type 2 bubble because it's very fragile and it easily perforates. You might aim of getting additional type 2 or type 1 bubble. If so, manage as possibility number 1. I'm going to go back for the outcomes. Either type 2 bubble together with type 1, then you manage as classical case. Type 2 bubble with surgical emphysema, forget that you got a bubble. Continue as manual DALK. Type 2 bubble alone, you might have another retrial of getting type 1 bubble, and then you continue classical, or you fail, then you have surgical emphysema, then you continue as manual DALK. I hope that I made myself clear in this schematic decision making in your mind. Of course, we have what's called for beginners. I believe that I stopped doing the positive bubble test since a very long time, except in extensive surgical emphysema. What is the positive bubble test? If we inject air into the anterior chamber, because of the presence of any type of the bubble, whether type 1 or type 2, the air bubble which is present into the anterior chamber will be locked into the angle. So this means that it will take the semilunar kidney-shaped boundaries and will be pushed by the convex shape of the detached desmus membrane, secondly, the big bubble formation. is beneficial when you are in doubt, especially when you have surgical emphysema. So this is a schematic for the bubble. Here, this is the big bubble, whether type 2 or type 1. We're not going to discuss that. We're going to discuss the bubble which is present into the anterior chamber. As you see, it's pushed to the angle, and this is why it's taking the pattern of the donut or half of a donut in the periphery. You only do it when you have surgical emphysema and you don't see the presence of the bubble itself. Once you deflate the bubble, this means that the big bubble, it will migrate to the center. Here you can see these are bubbles into the anterior chamber, and I'm going to inject the big bubble. Look at these bubbles. They are pushed into the periphery. Can you see it? They are here. If they coalesce with each other, they become a kidney shape, and they might be small, but they are all kept into the periphery in the angle. Once I'm going to deflate the bubble, this means that the anterior chamber bubble will go into the center of the anterior chamber. Always remember that I'm going to check the depth of my trephination gutter, and then I'm going to direct my pointer dissector upward. So deep, very deep into the cornea, and then directed upward to the apex of the cornea, and then introducing the air bubble, the air cannula bubble. The air cannula here, as you see, here is the dimple sign. I want to stop here. Can you see this? Okay. This is the dimple sign because of the concavity of the cornea, because I'm pressing with the air bubble backward to the anterior chamber, so it's making a concavity in the cornea. It will give this reflection. Once I get this reflection, which means that the cornea is indented concavely backward, once I get the air bubble, there will be vanishing concavity, vanishing dimple sign, because now I have the big bubble with a convex contour. So once I inject, no dimple sign again. If I get the smaller bubble here, this means that I have to go with the paracentesis and then continue injecting the air so that it will expand to the trephination edge, okay? But if it's already bigger than the trephination edge, then I'm that sure that there are no intertissue bridges between the stroma and the remaining Duas layer. So if I'm going to remove the quadrants, everything will be okay, and I'm not going to experience any perforation while removing the quadrants of the stroma. Here, you can see that I'm going to gain type 2 bubble. Look here. Of course, you can see that this bubble is, number 1, transparent. Number 2, because it's under Duas layer, it's transparent and it's big going to the periphery. This means that I got number 2 bubble. What you will do, because you didn't get type 2, type 1 bubble, then try again number 2, another injection. So you might get air bubble type 1, or you continue, you get surgical emphysema, then you go for manual DALK. Here, you can see that there is surgical emphysema all through. I'm trying to get many tries. Did you see that? I want you to focus here, because you will see that there is an edge of transparent bubble going to the, almost to the limbus. This means that this is type 2 bubble. What are you going to do? Resist the temptation of getting type 2 bubble. Consider yourself that you didn't get anything and you have surgical emphysema, then you're going to continue into manual DALK. Here there is surgical emphysema. This is number 3 of the possibilities. Getting type 2, type 1, and surgical emphysema. Now we are going to talk about the stromectomy, we finished talking about the stromectomy, we're going to talk about opening of the big bubble, or what's called the brave slash. So upon the roofing of the big bubble, there is a release of the stromal air bubble, and the bubble in the anterior chamber moves to the center of the anterior chamber as it is seen here, shown here. So the injection of the viscoelastic after releasing the bubble and the remaining deep stromal layers of the descemet membrane facilitates the removal of the residual stroma. But now we want to discuss the ways of doing the brave slash. Here you can see the brave slash. I'm going to repeat it again. What's in here is that the tip of the super blade is directed towards the bubble. What happens is that why it's called brave? Because actually it's not brave. It's a coward slash, because once the air bubble goes to you, you have to withdraw your hand. It's not brave. You're withdrawing your hand because you're very afraid of touching the Duas layer and descemet membrane. It's unbrave slash. Okay, let's talk about the wisdom slash. I'm going here to mark my incision, and I learned from Sarnicola, Vincenzo Sarnicola, that whenever you go with a keratome like this, now the direction of the keratome is completely directed towards the apex of the cornea. This means that you have a tunnel. And at the same time, it is elongated. So the escape of the air is very slow. Number three, always put in mind that while inside, you can keep the air bubble trapped, which means that the air bubble will not escape from where it is, except when you withdraw your hand. So you compare between this one, which they call it brave slash, and I believe it's not a brave slash. It is kind of like immature coward slash, because you withdraw your hand. Meanwhile, here you use the keratome as I show here, and you can keep the air bubble as far as the keratome is inside of the tunnel. So you trap the air bubble inside. The air bubble will escape very slow, as you see. And because you're directing your tip of the keratome upward, you will never touch the descemet membrane. I hope that this is clear. And then I can separate with the viscoelastic before doing the stromectomy. In brave slash, the tip of the blade is pointing vertically towards descemet membrane. It's better to open the bubble with the keratome long and superficial tunnel, and with the courtesy of Vincenzo Sarnicola. Thank you very much, Vincenzo Sarnicola, for teaching us this. Putting small amount of helon will control the escape of air, but put in mind, it sometimes makes the depth perception of the penetration kind of like deceiving. Mark with gentian violet in order to always find your opening. And then we are going to do the 7th step, which is the cruciate stromal dissection after big bubble escape. This is why I thank Georgia Surgical for having the blue titanium instruments. I wanted to look at this part because I want to cut all the intertissue bridges which are present at the edge of the big bubble. So if the edge of the big bubble is small, this means that there are adhesions between the stroma and the remaining Duas layer in the periphery. While you are cutting at the one of each quadrant, you might cut the intertissue bridges and you gain perforation. Because you're going to do mechanical dissection, especially in very wide trephinations like 9 millimeters trephination, you have to make sure that you see the bluish coloration further away, further peripheral at the edge of the graft or the trephination edge. So I'm going to show it in the video. So now I'm going to take the 4 quadrants, stop at the edge of the air bubble. Many surgeons, they don't use the helon or methyl because it's undue for them. Well, for the beginners, I will advise them to do that. I want you to stop cutting like 1 or 2 millimeters away from the edge of the trephination. Once you do that, you make sure that all this area, 360 degrees, as I will show here, now you can see that the bluish edge is going peripheral to the site of the trephination. Thanks again, Georgia. As you see here, I will do that in all the quadrants, which means that I'm sure that all the quadrants will be removed without any problem, without having intertissue bridges, which if we cut, we might gain perforation and we see the gush of aqueous from the anterior chamber. As you see here, I can remove all the quadrants without any problem. I learned from Dr. Rajesh Fogla that if I'm going to remove the quadrants, I'm either doing the 4 quadrants with a vertical cut and another horizontal cut, which means that this quadrant specifically, let's go here. So if I'm going to have the quadrants dissected in a horizontal line and a vertical line, put in mind that this quadrant would be very difficult to remove, which is on my right hand, because I have to change the direction of the curvature of the scissor at this part. Meanwhile, if I'm taking like obliquely like this, so all quadrants will be removed in a much easier way of removing the 4 quadrants. Now I'm going to prepare for the trephination of the graft. And thanks again, Georgia Surgical, for having the artificial anterior chamber in a nicely manufactured manner. So this is a video of the parts of the artificial anterior chamber. I'm going to take the graft, put it here, saline here, and then I'm going to lock. Then I'm going to put the lower tissue retainer. There is a knob here so that I'm going to do the locking. Now I have a closed anterior chamber. If I inject saline here, and then I block, then this means that I have a cornea. The epithelium is facing the surgeon. Meanwhile, the endothelium is facing the depth of the anterior chamber. What is the privilege of cutting the donor graft from the epithelial side? Number one, you can easily avoid the area where there is pannus. We all know that cornea is coming from some countries. They have the trachomatous pannus. So I can decenter my trephine away from the pannus. Number two, because I am cutting the recipient from the epithelium downward, and I'm cutting the donor from epithelium downward, this means that the fitting of the edges will be more anatomical. And at the same time, the suturing and the astigmatism control will be much easier. Here, I'm going to do the centration as if I'm cutting the recipient, not the donor. Then I'm going to do trephination from the epithelial side. avoiding the trachomatous pannus. And then now the anterior chamber is, artificial anterior chamber is full of hilum. Then I'm going to take my lamella towards the donor. Last step, we're going to talk about suturing of the graft. So for suturing of the graft, we have to think about two things. Number one, taking care of the astigmatism, which are the sutures of the graft to the recipient. This takes care of the anterior surface of the graft, which controls your astigmatism, okay? But don't forget that we also have to take care of the recipient descemet membrane. The recipient descemet membrane has a bigger diameter than any graft, especially in ectatic conditions, because it's very curved. It's very ectatic. So this means that no matter what is the size of the graft is shorter or smaller than the curvature of the donor or the descemet membrane of the recipient. So the graft size to donor bed size may be same size in high myopes or a difference of 0.25 to 0.5 bigger diameter millimeter. Then we are going to put 4 cardinal sutures to get the classical diamond shape as will be shown in the video. In between these 4 cardinal sutures, I'm going to add again 4 cardinal sutures, or 4 sutures additional to the previous cardinal sutures. Then I'm going to put additional 8 sutures between the previous 8 sutures, a total of 16 after going through this schematic. Then I'm going to use the surgical keratoscope in order to see if my sutures are equally tightened or no. This is under the title of taking care of astigmatism, sutures of the graft to the recipient. Taking care of the recipient descemet membrane, which has a bigger diameter than the graft. In all ectatic pathologies, descemet membrane will be stretched, so the diameter will be bigger than the diameter of the graft, especially in advanced ectasia. And in order to decrease the effects of the folds, we have to inject air into the anterior chamber in order to stretch the descemet membrane as much as possible. And after taking our sutures, there will be wrinkles in descemet membrane, which might affect the vision if it crosses the visual axis. So in order to deal with those wrinkles, go with the Sinskey hook in the graft bed junction to stretch the descemet membrane as well be shown in the video. So this is schematic of the transplant and the suture. And here is the 16 sutures. We are going to go for 1 and 2, 3 and 4, 5 and 6, 7 and 8, 9 and 10, 11 and 12, 13 and 14, 15 and 16. Let's repeat that again. Okay. And these are different types of sutures, whether it's interrupted or continuous. And for the continuous sutures, whether it's torque or anti-torque or combined shoelace. But the embedding is extremely important. Why? It's extremely important because the knot might invite vascularization, like in penetrating keratoplasty. So it's extremely important to embed the suture. And you always remember that you keep the knot near by the site of the embedding. I'm going to show here the marking. Always remember it's dry. If it's not dry, then the marks will be kind of like diffusing all over the surface and you will never see your sutures. I'm going to take full thickness and then going to the bed. These are the first 2 sutures. You might as well use the Bond's corneal forceps where you have 2 sutures, but for all our beginner colleagues, I want you to see this diamond. Why? Because later on, I'm going to take a suture here. So the diamond will be 8 edges. So suture here, suture here, suture here, suture here. So instead of having 4 limbs, we will have 8 limbs. As you see here, there is air into the anterior chamber in order to stretch as much as possible the descemet membrane. I'm going to take the first suture again. Sometimes my colleagues ask me, do you have difficulties in getting the suture, and then while tying, you might as well lose the knot or something like this? What I do is that I leave my assistant nurse sitting where she is sitting. And what I do is that I have this garage parking position. So I take the suture as here. This is suture number 1. When I'm going to go out, I'm not going to leave the suture away. I'm going to put the needle in a parking garage position here. So once I put it here, I know where I'm going to pick it up later on. And then I'm going to take tying my knot 1, 1, 1, 1, or 1, 2, 3, whatever. And now I'm going to continue my second suture without telling my assistant nurse to give me the thread or the needle. Now I'm going to take the third suture here, but I'm going to leave the needle in a parking garage position in the opposite direction. And once I do that, I know that I finished my 4 cardinal sutures. For the following 4 sutures, I'm going to take the suture here, then parking garage position in the opposite mark. Then for the remaining sutures in between the 8 interrupted sutures, I can take them, in order to save time, I can take them kind of like continuous, but I'm not intending to do them continuous. I'm going to cut in between the sutures. So I took 1 bite here, 1 bite here, 1 bite there, 1 bite there, and then I'm going to leave the needle here in a garage parking position. Leave it here. And then you start doing tying for each knot. Well, I'm doing that in order to save as much as I can from my thread, because sometimes we use it for many cases, or we use the remaining part for socioeconomic reasons. Then as you see, I'm cutting all the sutures, doing the knot, then cutting, and then repeating the same. Always remember, the thinner the knot, the easier there will be the embedding. So I'm finishing, doing the knot, embedding the knot, and so on. Taking care of the recipient descemet membrane, because the descemet membrane, which is having a bigger diameter than the graft by stretching, will need some sort of stretching at the periphery of the graft-host junction. Once I put my graft and take the sutures, the membrane will be kind of like folded, okay? So I have to go at the graft bed junction here and here, 180 degrees opposite each other, and do some sort of stretching so that the folds will be driven to the periphery. It will not affect the visual axis. You can see here that I'm stretching my descemet membrane. I increase the air bubble into the anterior chamber, and then I stretch into the periphery, 180 degrees, by using the back of the Sinskey hook here and there in order not to see all these wrinkles. Be patient, because as much as you take care of stretching the descemes membrane after finishing the sutures, this means that you will have a very elegant outcome regarding the folds of descemes membrane. So with the add of a big bubble into the anterior chamber and the stretching, all the folds can go into the graft bed junction into the periphery and not crossing the center, the visual axis. The last thing is that you're going to use the surgical keratoscope. Why? Because you want to make sure that your instruments, the mires of the surgical keratoscope are circular, and then you have a minimal amount of astigmatism. Okay? What if we fail to get the big bubble, whether type 1 or type 2 bubble? Then we have to move to manual DALK, and we have also to get ready for this possibility. As you see here, I'm going to do the trephination, centration as usual. 7 quadrants to 8 quadrants. Then I'm going to do the stromectomy. From the beginning, I knew that the bed is kind of like 200 or something. So if I try to get the big bubble, I will have surgical emphysema, which I don't mind at all because it increases this silver whitish part and it makes the dissection easier. But I want you, once you finish the initial stromectomy, I want you to go to the orange peeling technique, which is I'm going to introduce some sort of an incision in the periphery like this. Then with the aid of the air cannula, because it's very blunt, so I'm trying to introduce my air cannula. It's very blunt. It will create the initial tunnel. Once I go, I have this pocket dissector, which was designed by my mentor, Rajesh Fogla, and use the Hilton method of opening a closed space. So mechanically, you're going to go 360 degrees all around. Then you continue doing a narrower circle. Once you reach the thinnest part of the stroma here, you will shift to Malbrun's pulling technique. So it is mechanical dissection using the air bubble, as I show here. Introducing the air bubble, we introduce the initial tunnel, then using the Fogla's dissector, then cutting with a scissor, and then I try as much as possible to go towards the central part. Here, peeling is very easy, and the dissection is much, much easier. The more you go closer to the descemes and duos layer, the more you will get easier dissection. And you are justified to get as thin as 100 micron, and this might be very useful and safe to the patient. As I show you again, I don't cut except if I see my dissector going to the periphery of the edge. And I can measure with the pachymetry what is the remaining stromal part. In my country, we use 1 graft for 2 patients. So we remove the descemes membrane, 10 millimeters descemes membrane. And once we separate the edges, we go into scuba diving. And We use the occlusole as the red reflex background. And then we separate our membrane. And then we put the graft on its epithelial side up over the anterior chamber. And then we cut from the epithelial side, then we suture to the recipient. Now we get the patient for the first day post-operative follow-up. We have to check the integrity of the epithelium. We have to check the pressure digitally. We have to check the adherence of Descemet's membrane, because if we have something like this, this is double anterior chamber. So if we have a double anterior chamber, then we have to inject air into the anterior chamber or augment or increase this air bubble in order to support the Descemet's membrane. Of course, if we have an inferior iridectomy here, this means that we are not afraid of pupillary block. And we have to check for no peripheral anterior synecdoche, no posterior synecdoche. We have to check for the astigmatism, but this is not for the first day post-operative. For the first day post-operative, you check for the first 4 points. But for checking the astigmatism would be maybe after 1 month. And you might need anterior segment OCT if you're in doubt if you have double anterior chamber or no. Astigmatic control by stitch removal. Selective removal of stitches as early as you get stable refraction, at least kind of like 2 or 3 successive visits. Then not more than 2 sutures 180 degrees away in each visit. Removed sutures in the steep meridian. Remove the sutures by if starting to invite vascularization. And always pull the end of the suture towards the limbus, because if you pull centrally, you might induce some sort of disengagement of the graft bed junction. So you pull towards the limbus, not towards the center of the graft. So you can see here at 10 degrees astigmatism. What are you going to do? You're going to remove these sutures. Imagine that this is after 10 minutes of removing the sutures, the astigmatism became on the autoref 2.75, from 10 diopters over the pentacam to 2.75 immediately 10 minutes after removal of the suture. Well, thank you very much, Dr. Rania Sobhi, for helping me in this course. And I hope that I was giving some sort of simplifying the steps of the DALK procedure. And thanks to all who taught me a lot in order to transfer what I know to my colleagues. Thank you very much, everyone.
Thank you, Dr. Yasin. It was a wonderful talk. And you know, the aim of this program, Corneal Surgical Learning Course, is to teach the general ophthalmologist and young budding corneal surgeon the corneal surgeries step by step, so that they can reciprocate that in their practice. And you gave us a wonderful beginning to this course. And all this step by step learning of DLK, that is definitely going to help the young surgeons. And I would like to go to our experts, Rajesh Pogla sir, Namta Sharma ma'am, Amit Gupta sir, Uma Sidhar ma'am, Rajesh Sinha sir. Any comments or anything that you would like to add here?
So after what Dr. Azim has taught, there's hardly anything to left to add actually, because he's so wonderfully and beautifully demonstrated small tips and tricks which people will not tell, or will miss. So I think each and everything, how to make a slash, how to do dissection, everything, and pros and cons of each, paracentesis before, paracentesis later. I think each of the things was dealt really very well. I just have a question, Dr. Azim. What is although you did mention, but what would be the thickness of the cornea in a case of keratoconus where you would not attempt a big bubble?
Well, in all situations, no matter how thin is your cornea, you are going to try to get the big bubble. Why? Because even if you have 100% belief that you're not going to gain a big bubble, the trial of getting the big bubble will induce the surgical emphysema. And the surgical emphysema itself will facilitate the decision changing to manual DALK. I mean, you want to increase the thickness of the stroma if it's very thin with air or saline. So this will facilitate the manual DALK. So I will go for big bubble in all cases. Either I get a big bubble or I have the belief that I'm not going to get the big bubble, but I at least get the surgical emphysema, which will help in the future DALK. But we can say when you do the stromectomy, before trying the big bubble or no. This depends on the initial thickness of the central part of the cornea. If it's more than 400, then I'm going to do initial stromectomy. Then at the bed of the remaining stroma, I will inject the air. If it's between 300 and 400, then I'm going to do initial stromectomy in the upper 1/3 and then try my big bubble, because in the lower 1/3 or the lower half, it's very thin. So the roof of the bubble might not retain a big bubble. It will retain very small frothy bubbles escaping through this thin roof. And if it's less than this, I'm 100% sure that I'm not going to get a big bubble type 1. Maybe I will face the situation of having big bubble type 2. So I will do it in order to get the surgical emphysema.
So Amit, do you have a cutoff? I normally like to keep a cutoff of 250 microns. So if the cornea is thinner than 250 microns, then, you know, I would be a little skeptical about doing big bubble. But like cornea, I mean, like, or you can say like all DALK surgeons, you always want to try big bubble first before, you know, you change your course of action.
Yeah, but
Yes,
go ahead.
yeah, I think I agree with Dr. Namrata. I'm a bit cautious about patients with very thin cornea, and also because we have that the Descemet's folds to deal with. You showed it in such an excellent manner, how you smooth them out with the periphery, with the back end of the Sinskey hook. I think it was a wonderful technique, and I'm going to try that. One question I have is, which syringe do you use for forming the bubble in the patient, which is attached to the cannula? Which syringe do you use?
So I use the 5 cc's or 10 cc's. The 10 cc's actually gives me kind of like a better expansion of the big bubble, because I'm not kind of like injecting forcibly. I just induce some sort of slow injection, and this, when it goes through the 10 cc's or the 5 cc's, it induces the expansion of the big bubble. But back to what you said regarding the thickness and what Professor Namrata said, when you have a very thin cornea, you don't aim of injecting the air bubble with the direction of the tip of the needle towards the center of the cornea. No, you go tangential, parallel to the edge of the trephination, which means that you are going to have the surgical emphysema at the periphery, concentric with the trephination edge, because this is the area which you know that it's thicker, and this is the area which is not going to give higher incidence of the type 2 bubble. So instead of going to the center of the graft or the center of the cornea, you're going to go tangential and parallel to the edge of the trephination.
How do you tackle a thin edge? I mean, when you're deciding the sizing of, you know, how much of you want to trephine, when you look at the pachymetric MAC preoperatively, so sometimes we get a thinner edge, and it can be a big problem for beginners to suture it properly and have complications of suturing.
Let's agree that it's very important to examine the patient with the blue filter and the yellow filter on the slit lamp, and to see the pigmentation ring of the Kaiser-Fleischer ring in order to see the extent of the ectasia. sometimes the ectatic cone in keratoconus is eccentric. And it's extremely important that if it's eccentric, this means that you have to get a wider trephination like those which you saw me doing the trephination of 9 millimeters. Why? In order to include all the edges of the keratoconic part. So it's extremely important to do dots over the slit lamp, even on the thinner part of the keratoconus, and even away, more peripheral, away from the pigmented part of the Kaiser-Fleischer ring. And in all situations, if you're not getting the whole part of the keratoconus, is extremely dangerous because you will have some sort of disparity at the edge of the graft-host junction.
Yeah, Dr. Hazem, one more question is that with different types of contact lenses coming in, a lot of people are happy with contact lenses. So how bold are you, and what are your really indications, in particular in keratoconus patients, of when to take up the patient for DALK surgery? I mean, with the Boston scleral lenses, semi-scleral lenses, many of them tolerate well. So when do you decide, listen, this is a patient I want to do a DALK aggressively?
Number one, if I have some sort of central corneal thinning progressively on each visit, even by pentacam, or if I'm kind of like getting some sort of intolerance of the patient to the contact lenses, and some of the patients, they come with starting ulceration in the thinnest part of the cornea, even without any progression of the keratoconus itself, because the surface of the cornea is getting kind of like friction with the lenses while removing it, inserting it. So once I feel that there is something like this, especially in younger ages, I don't wait. Put in mind, the more you wait, this means that you're getting thinner cornea with higher possibility of getting type 2 bubble or complicated DALK, or DALK which is not going straight forward. And the more you decide that you're going to take the patient into the operating room, the more fruitful outcome of the big bubble and the outcome of the whole procedure.
Is there any difference in dissection cross-linked corneas versus non-cross-linked corneas?
Well, in my country, I have a very big concern about that, because many of the general ophthalmologists, they deal with the cross-linking as if it's additional benefit to the patient, as if we are going to give him augmenting vitamin to the tissue, which is completely wrong, because it is a double-edged weapon, and it can harm the patient as much as you think it will get benefit to the patient. So it has its very unique and precise indications. It's not for everyone. And for me, definitely, when a patient is having a cross-linked cornea, number one, the expansion of the big bubble and getting the big bubble is more difficult. The dissection with manual DALK is more difficult. So whenever I have a patient with cross-linked cornea, I know that my procedure will be challenging.
Well, thank you very much. Congratulations. I truly enjoyed your very thorough presentation. I think everybody is going to gain so much out of it. Thank you. My comments are over.
Thank you, sir.
Praful,
Doctor,
thanks.
yes, sir. Rajesh Fogla, sir, are you there? Rajesh said Dr. Uma Siddhas, ma'am. I think they got disconnected somehow. Dr. Vikas? Yeah, Fogla sir is here. Sir, any comment, any addition, any deletion?
No, nothing to comment. I think Azam did a wonderful job. He has collectively taken all the great points from various surgeons across the world and combined them in his talk. And I think it was very, I think this should be recorded, and maybe AIOS should keep it as a resource for people learning DALK surgery. I think this is a very nice overview. He has used a lot of animations and beautifully edited videos. And I think he has gone over each and every concept, every reasoning behind each and every step, that I think which will help people understand the technique better and make it easier for them to transition to performing a big bubble DALK. Congratulations, Hazem, for a wonderful lecture.
being a
We are
student.
going to, DOS is going to create an archive of all this corneal surgery learning course, and that will be available to all of us. Only one question, Rajesh sir, do you prefer keratome for this brave slash?
It's a great concept. Whether you
Yeah.
use slit knife or you use a keratome, the risk of perforation would be the same if you do not follow the basic principles. I think the first thing, why is it called a brave slash, is that there should not be hesitation in that step. A lot of time, it's the hesitation that leads to a partial leak. The air leaks out, and then when you go ahead, you end to perforate. So remember that if you have a big bubble, there is ample space that has been created. When you put in your knife, whether you put in your keratome or you put in the slit knife, the air doesn't leak out. It's only when you're withdrawing that the air leaks out. So the withdrawal should be pretty quick. And if you do put a bit of viscoelastic, it retards the egress of air and makes it relatively safe. Just loosen the speculum so that posterior pressure is reduced. Release fluid from the paracentesis, that also softens the eye so that the posterior layer does not jump up immediately as the air is puffed up.
Thank you, sir. Any comment from our panelists, Dr. Shefali, Dr. Aditi, Dr. Pranita?
Yeah. Am I audible?
Yes, Aditi.
Thank you, Dr. Hazem, for the wonderful lecture. I have a doubt. So what is your opinion regarding cases post-hide drops, the scarred cases after hide drops, they have scarred. And in such cases, what is your take?
Okay. So actually, in probably like many years ago, whenever I have a patient with acute hydrops or a previous hydrops, I used to go for penetrating keratoplasty actually. Then I got the carriage with the aid of my mentors like Rajesh Fogla and Vincenzo Sarnicola, that even if you have a patient with acute hydrops or previous acute hydrops, do not hesitate to try to do DALK. But in these cases, please avoid doing big bubble DALK. What you're going to do is manual DALK, as I showed you, peeling orange technique in the periphery. Once I go into the center, I do use the Malbrand's technique. But because I know that there is a defect in the posterior capsule, in the posterior surface, like the desmus membrane, so I know that peeling with Malbrand technique might induce a bigger size of the tear of the desmus membrane. So once I reach the area where I know that it is the previous desmus membrane tear due to acute hydrops, I start using, again, a sharp dissection. So even if I'm leaving kind of like residual stroma at this area, if it's away from the visual axis, be sure that it's not affecting the patient visual acuity. And at the same time, it's carrying better ergonomics, it's carrying better future corneal tissue surviving for the patient. So if the acute hydrops is away from the visual axis, or it's a very minute residual part, so go for manual DALK. And the other thing is that I noticed that the remaining scar of the acute hydrops, it all depends on how early you're going to manage the acute hydrops. I mean, if the patient coming to you today with an acute hydrops, and then you take a compression suture together with expansile gas, this means that the residual scar will be very minimal, maybe linear. And if it's away from the visual axis, go ahead for manual DALK.
Thank you so much. Thanks a lot, sir.
Thank you, sir. It was a wonderful lecture, sir. And in our scenario, we usually do DALK more for healed keratitis scars. So we do more manual DALKs in India rather than doing more big bubble. So, sir, I just want to know, suppose I'm doing a very good manual DALK But as it is not required, we don't do paracentesis in the beginning. So sometimes at the time of deeper dissection or even at the time of suturing, perforation occurs. And at that time, AC, collapses, and it is very difficult to do paracentesis at that point of time. So what you suggest for the beginner, should we do paracentesis in every case, even in the manual DALK? It's a good way to go ahead.
Well,
We can
again,
salvage our case in a better manner.
well, again, if you're going to do paracentesis in manual DALK, this means that you're going to use air bubble into the anterior chamber. Why you're using air bubble into the anterior chamber? Because it works like a backward mirror. So it gives you kind of like a reflection on how deep you are from the Dewey's layer and how deep you are in doing the mechanical dissection. But if you succeed to do the manual DALK without going into paracentesis, there is no problem at all. The issue is that you have to go as deep as possible with the orange peeling technique, orange dissection technique in the periphery. And once you go towards the central area, because you're approaching the Dewey's layer, this means that the pulling technique of Malbrand's will be much easier. The separation of the lamellae will be much easier, except in the area where you have the scar, the previous scar. You know that you need to take the sharp crescent knife in order to remove all these tissues, because the peeling here will induce some sort of perforation. But you don't have to go for paracentesis if you're going to do manual DALK, except if you're going to use the air as a guide for deeper manual dissection.
Yes, thank you so much, sir.
Thank you. And now I think I'll have to make a request to my discussion for today. Dr. Saran, Dr. Soham, can we take up all your cases, Dr. Shraddha, in our second episode of this series? Because we have already, it's already almost 9 p.m. We are touching 9 p.m. So can we do that? Soham, Saran,
Absolutely.
Shraddha?
Yeah, I think Professor Yasin did such a fantastic job.
He's going to do an episode 2, and that will be
Wonderful.
dealing with
So I don't
challenging
think there are
cases
too
and
many
complications.
cases or scenarios which he did not cover. It was absolutely fantastic. So not many doubts as such. So please.
Agreed, completely agreed. Excellent talk, sir. I mean, you have spoken like all tips that we need, not only for beginners, I feel even for people who are doing DALK regularly, all the tips will really help us refining our surgical techniques.
And just to update you all, throughout the webinar, we have on an average 180 live views, and total 289 people joined this program to watch this webinar. So thank you, Dr. Hazim. It was a hugely hit webinar for us, and we are going to do episode 2. All of the panel will keep the same, and discussion like Soham, Saran, you had some cases to discuss, we'll take up in our next episode. And Dr. Rohit sir, if you are still there, you can conclude. And a big thank you to Joja Surgical for taking up this initiative.
Many congratulations, Praful. You've done a wonderful job for the first session. It's so fantastic. And we really enjoyed this. Thank you so much.
Thank you, sir. So I think Rohit sir is not able to log in again. So let's conclude here. Thank you, Dr. Hazim. I will email you and WhatsApp you the next date for the part 2 of this DALK learning course. And good night all.
Thank you
And
very
thank
much.
you for joining.
Good night.
Night.
Much was excellent session.
Thank you. Good night.